What up, guys? Welcome to my video on RSI, or rapid sequence intubation. This is going to be a quick review talking about a residency level intubation medications. Let's get started. What are we going to learn today? What are the rapid sequence intubation meds? What dosages do we use? What are the pharmacokinetics, like the time on, time off? What are the side effects? Before we get started, this is a graph from Rosen's. It's a really cool graph basically saying that you actually have more time than you think if you pre-oxygenate your patients before they desaturate. So in a normal, healthy 70-kilogram adult, you have around 7 to 8 minutes until the O2 sat starts to drop after you give the paralytics. And this number changes with obese adults. You can see for an obese adult, you only have between two to 3 minutes for the oxygen saturation to drop. And for a moderately ill adult, you'll have between 4 to 5 minutes until the oxygen saturation begins to drop. This is the master slide. Basically, rapid sequence intubation can be divided into three categories. You can pre-medicate the patient, then you put the patient to sleep or you induce them so they don't feel that they're being paralyzed. They don't remember that they're being paralyzed, and then you paralyze. So to pre-medicate, the medication that I've seen used most often is fentanyl, which is an opioid analgesic. One important positive effect of fentanyl is that it blunts the effect of catecholamines. So when you intubate with, when you give something like ketamine, for example, ketamine will increase your heart rate and blood pressure, but if you pre-medicate with fentanyl, this effect is a little bit less pronounced. So you can pre-medicate patients with fentanyl, and it's also good for pain control as well. Then after you pre-medicate, you put the patient to sleep. So agents that are often used are Etomidate. A big benefit with Etomidate is that it's hemodynamically neutral, doesn't affect the heart rate and blood pressure. But the one thing to be careful about with Etomidate, or the two things, I guess, is relative contraindication is somebody that's like septic and has adrenal suppression or needs their adrenals to, sorry, not has adrenal suppression, but needs their adrenals to respond to some kind of physiologic stress. So you would also give high dose corticosteroids, stress dose corticosteroids to supplement the adrenal response, which Etomidate blocks. Also, Etomidate can lower the seizure threshold, and you should avoid it in actively seizing patients. Although in UpToDate, you technically can use Etomidate for seizures. So even though this is in red here, it's not, it can still be used in patients having seizure. Just be careful and know that it's one of the contraindications. Ketamine is great because it's a bronchodilator. It's a phencyclidine derivative, so it's similar compounds to PCP. It releases catecholamines, and it's going to bronchodilate your patient. It's going to increase heart rate and blood pressure. It's really good for patients with asthma. Propofol is kind of the opposite of ketamine in terms of its hemodynamic effect. So it's going to decrease your blood pressure and heart rate. One way that I kind of remember this is because when I was shadowing an anesthesiologists, they like to use propofol to keep their patients sedated. And the anesthesiologist told me that if you want to know if a patient has real hypertension, when they're sedated with propofol and they're still hypertensive, that's when you know that someone has actual hypertension and it's not just white coat hypertension. You could also use midazolam or Versed to sedate somebody, to induce somebody before you paralyze. And the one downside to it is it has a longer onset of action. So then once the patient is adequately sedated and is unable to remember that they're going to be paralyzed, then you choose a paralytic. So the two that we most often go with are Succinylcholine or Rocuronium. So Succinylcholine has a ton of contraindications or warnings if you look at Rosen's. Some of the ones that I want to touch on are specifically it's contraindicated in patients with a history of malignant hyperthermia. or even a family history of malignant hyperthermia, which can be life-threatening. So you want to be extremely careful using succinylcholine in these patients, or avoid using it at all. Also, if someone is 5 days or more after a crush or burn injury, you want to avoid using succinylcholine because it can induce hyperkalemia. Also, if somebody has neuromuscular disease like ALS or MS or a recent stroke or spinal cord injury, you want to avoid using succinylcholine. Also, I just had a lecture on in patients with myasthenia gravis, you would have to use a much greater dose of succinylcholine to achieve a paralysis effect because it's a depolarizing neuromuscular agent. So myasthenia gravis, you block the acetylcholine receptors, so it takes longer to depolarize the neuromuscular junction. Whereas with rocuronium, the opposite happens. So it's a non-depolarizing agent, so you need less of a dose of rocuronium to induce paralysis with somebody with myasthenia gravis. For rocuronium, the upside is that it's neutral hemodynamically compared to succinylcholine, which induces hypotension or bradycardia. Because remember, succinylcholine, it stimulates the acetylcholine receptor, so that means that it'll induce a higher vagal tone, but rocuronium doesn't do that. But the thing with rocuronium is that it lasts for 40 to 60 minutes. So if you see up here, it's going to last 40 to 60 minutes. So you make sure you sedate the patient adequately after you give rocuronium, after your initial sedation. So you would want to put them on a post-intubation sedation, even for patients that don't require ICU level of care right away. You want to either put them on a propofol drip or a benzodiazepine drip. It's not really a drip. You just give 2 boluses of midazolam or 1 bolus of lorazepam because lorazepam acts longer. And that's pretty much the master slide. On the next slide, I have a quiz for you guys. So take a minute to kind of look at the slide, and then you could look at the quiz. And here's the quiz. Sorry, these are 2 practice situations. So before we get to the quiz, these are the practice situations. These are situations I made up. We have a 9-year-old with a history of acute coronary syndrome. They have crush injury after motor vehicle collision. They're given etomidate and succinylcholine for intubation. And then you look at the EKG and it shows T-wave changes. So you might think, oh, succinylcholine, crush injury, we just induced hyperkalemia. But since the crush injury just happened, it's likely that the T-wave changes can be due to a new MI because it takes 5 days for the hyperkalemia to be a significant, like 3 to 5 days, some sources differ, for hyperkalemia to be a significant comorbidity of administering succinylcholine. Then the next case, we have a 28-year-old female given ketamine and rocuronium for an asthma attack. Vital signs initially after intubation are 85 beats per minute heart rate and 120 over 80 millimeters of mercury for blood pressure. And 30 minutes after being intubated, her heart rate jumps up to 130s and her blood pressure is 160 over 90. So what's going on here? So what you guys should be thinking about is the fact that rocuronium is a paralytic that works for up to an hour. So if you only give ketamine, ketamine lasts around 30 minutes to 45 minutes sometimes. So you really want to make sure that you give this patient extra sedation with midazolam, for example, or propofol, so that this patient doesn't freak out. And patients that are not adequately sedated and paralyzed can develop PTSD and become severely psychologically distressed for the next few years, or if not for the rest of their life, because of this. So definitely don't make this mistake. And here's the quiz. You guys can pause this and just match the letters on the left to the medications on the right. And I just want you guys to give the doses and the benefits or downsides of the medications. As you see them on the next slide, there's going to be the answers. And here are the answers. Thanks, guys.